and it's always negative. So I have no idea why I've been coughing. I'm assuming it's allergies. Depression. Okay, so characteristics of mental health and aging. Okay, so depression. It's not a normal part of aging. We can't assume that everyone who's older is going to be depressed. Actually, a lot of the times we think, you know, our patient who's 75 and older, we often misdiagnose depression and dementia. And that's not really a great thing. I think I mentioned this when we're talking about depression, but it's not normal. So if your elderly patient is exhibiting depression, intervene. Intervene. Aging and suicide risk. This is a big deal. Right? White males older than 75 are at highest risk. Okay, anxiety. I'm briefly going to go through this, but this is pertinent. So delirium, very common in the elderly. Delirium. What's the underlying cause? Let's fix it. Lots of infection. They use lots of meds, right? We're going to assume if they use more meds, since this is nursing and it's like worst case scenario always. What med can possibly, there's so many meds that possibly cause them to be delirious. So fix underlying cause. Go back to premorbid stage. Neurocognitive disorders, alcohol use. Elderly patients are often lonely, right? Their children are married with their own families. Maybe they don't see them that often, and they don't, lack of coping mechanisms. So they use lots of substances. When I have elderly patients I visit, I try to stay longer than necessary just to talk to them, just to be there for them. Like, hey, how was your day? What did you eat today? What did you watch today? What are your plans? Are you reading something? Things like that. Pain perception is very different for the elderly than for us. Oftentimes they won't report pain because they're kind of feeling embarrassed. So we utilize, like the faces scale with the happy faces, and I always say, okay, well, if you can't report it to me, at least show me where you're at. So these are things, mental health issues related to aging, all of this. Okay, pain barriers to accurate pain assessment. So you guys, I'm pretty sure you guys know this. Wong-Baker Faces Pain Rating Scale. This is the one I always use for them. Just show me where you're at. You don't have to give me a number, okay? Um, these are also things you can use. I'm not going to touch on it. Pharmacological pain treatments, non-pharmacological pain treatments. So a lot of my elderly patients, they just are not compliant with their meds. They just don't take them. So it all depends on their diagnosis. If my patient's exhibiting a little, dementia or anything, depends. It could be 65, it could be 70. I have it in my duffel bag with all my elderly patients. So 65, 70, around that time. And it always depends on, if they have dementia, if they're, am I making sense? But if they're 65 and they're good and they're alert and they're oriented, I won't use it. But sometimes I still do. They enjoy it. And so they won't utilize their meds. I don't know what it is. They don't comply. They're afraid to use it. Sometimes they can find it. Sometimes they can't read it because their glasses aren't working. So, and sometimes they forget. So, a lot of my home care hospice patients, we have the little boxes that say Monday, Tuesday, Wednesday, Thursday. So I make sure that they have all their meds, and I tell them, hey, I'm gonna educate them. This is for your pain, and it's here for every Monday. You're gonna take it. Things like that. Non-pharmacological pain treatment. They want to be independent, right? They want autonomy. They do. And so I told them, okay, well, if you're exercising, make sure you incorporate frequent rest periods in between. That's very important. Sometimes they overdo it and they get tired and they hurt themselves, right? All of this comes into play. Healthcare concerns of older adults. So financial burden. I often ask, have you been talking to your daughter about whatever is going on? No, I just don't want her to think that I'm a burden. I don't want her to spend a little more money. It's okay, I'll take care of it myself. It's kind of sad. It makes me want to give them a hug all the time. Okay, caregiver burden. This is very real, depending on how high of an acuity the patient is in. Um, Sometimes it's very hard to care for them because of the numerous issues that are going on. But um, so this is where education comes into play. You got to educate the caregiver, right? You got to offer breaks and incentives and help. So this is a thing. This is a thing. I don't touch on ageism, but there is a whole lot of public policy on ageism, respite care. Absolutely. Ageism in public policy, ageism in research. I don't touch on it. I don't dive into it, but it's there if you want to research it. Okay. Um, Everyone, as a nurse, the first thing you do when you walk onto a unit is you should check their advanced directives. Are they full code? Are they DNR? Okay. Um, a lot of the times nurses get sued because they fail to do that and they fully resuscitate their patients who are DNR. Okay. Um, please look into. I always do this. I always educate my patient on this when I'm admitting them. Hey, do you have a living will? Is there a directive to a patient? Is there a durable power of attorney? Is there guardianship? Educate them. When it, especially with the elderly, educate them on it. I don't touch on any of this. You can look into it if you'd like. I like this. This is very therapeutic. It might pop up. So when you're talking to your patient who's elderly, okay, private area, give them all the private. They don't want all their business out and about and out loud. Be respectful. Private area, okay. Close the door or close the curtain and talk to them and ask for their questions. Introduce yourself and ask the patient if he or she would like to be called by their name. I always say, Mr. and Mrs. Smith, out of respect, right? Out of respect, always say that. Establish rapport, putting the patient at ease by standing or sitting at the patient's level. If they're elderly, I always do this. I always say, hey, is it okay if I sit down so we can talk? Is that okay with you? Develop trust. When you're working as a nurse, don't dive straight into the problem. Develop some form of trust when you're talking to them. Hey, how was your day today? What did you do? Did you talk to your family? It shows that you care. You're establishing that like kind a kind guideline. Like, hey, I'm kind, I'm caring, and I'm not a robot. Okay. Especially with the elderly, they want to feel at ease. Okay. Ensure the lighting is adequate, noise level is low. Okay. In recognition, the fact that hearing and vision may be impaired. So this is not us being mean and assuming. It's just when you're caring for someone who's elderly, that's something that's always charted, something you should always consider: hearing and vision. So being considerate of that, decrease the darn stimuli, lower the light, okay? Ensure that it's appropriate and not hard for the eyes, and noise level, okay? Using touch with permission while at the same time respecting the patient's comfort level. Always ask, irrespective, um, tell them, hey, like, I need to inspect you, so I'm going to touch you. Is that okay? Things like that. And then once you're done, summarize the interaction. Hey, so this is what we did. This is what we talked about. We went over blah, 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 blah. Do you have any questions for me? You can ask me anything you want, even if I went over it or if you don't understand anything. That's what you should. You should be doing this with everybody, by the way. But like literally, you should be doing this with everyone. Humane care, therapeutic, but especially with the elderly, because there's so many other things we're considering, right? Intervention strategies: environmental, psychological, pharmacological, promotion of self-care, teamwork, and safety. I don't dive into this, but we always consider the environment, right? Maybe they're higher at risk for fall. Declutter. Psychosocial interventions. What are their interactions like? Pharmacological. Are they complying with their meds? Are they taking them? Right? Are they working for them? Do they have questions about them? Promotion of self-care activities. Promote autonomy. Incorporate frequent rest periods. Right? Because it has to do with pain. And teamwork and safety. You're working together with a multidisciplinary team. Okay. Care settings. Get this. So much is available. You can care for the elderly, skilled nursing facilities, residential care, partial hospital, day treatment programs like ADHCs. I used to work at one. behavioral health homes, community-based programs. It's really cool. A lot is available. Done. That was easy.